treatable. We've mentioned gait, we mentioned timed up and go, but I thought you needed to be on your feet before that. And thinking about contrast sensitivity as well as visual acuity. And I put this slide on before I knew what the audience was like. Think about the multidisciplinary team approach, because we've got a lot to learn from our colleagues who have expertise in different domains. So the role of physiotherapy, the role of the occupational therapist, and again, although I put it in small print at the bottom right, Donald, think about bone health. So just take you through somebody. This is a characteristic patient of mine. She's now 5 years on from her 87, because I keep bringing her up again. She'd had 2 falls in the last 2 months. She didn't trip. She describes lightheadedness often during the day, with mobility, when she stands up, when she gets up quickly. She's had a previous stroke, but there's not very much in the way of deficit left over from that. And she's on appropriate medications. She's on a beta blocker for a previous MI. She's on aspirin as an antiplatelet agent for that and her stroke. She's on a statin for her stroke and her MI. She's on lisinopril because there's very good evidence base that in secondary stroke prevention an ACE inhibitor is beneficial. She's on zopiclone, for which there's bugger all evidence. Sorry, I swore there, didn't I? But it's, something obvious there. But what are the causes? What else? What's going on with this lady? Shout out some causes. Why is she falling over? Postural hypotension, fantastic. Sedation, yeah. Gait and balance problems, because she's had an old stroke, yeah.
Vertebral-basilar insufficiency.
Vertebral-basilar insufficiency, I'm glad you mentioned it. I never see it. I don't think it exists. We're having a discussion at lunchtime about it. We see a lot of patients, and we've done patients looking at vertebral supply, and if you do MRA on patients who have those symptoms of dizziness, often those who look up and say they're dizzy and do that with neck extended, yes, you may well see some reduction in vertebral supply, but you will also see that in normal patients without symptoms. And I think it's got a biological plausibility that sits well with us as doctors, and it sits well with patients. They say, I'll go like that and I feel dizzy, and we say, oh, it's because those blood vessels in the neck kink, and they go, thank you, doctor, that sounds like a good idea. Yeah, I agree, that makes sense. Oh, well, we'll move on, shall we? And I don't think it's the problem. So on examination, she's not got aortic stenosis, which is good. She's a bit slow because she's on a beta blocker. Blood pressure seems to be fine because she's seen you in clinic. Vision, we often forget about that with stroke. So it's again worth remembering, just because they've got physical evidence of their old stroke, is don't forget their eyes. And she did have some unsteadiness with path deviation when she was walking. So what tests am I going to do? Bits of that. Head up tilt test, possibly. I mean, this lady does describe lightheadedness that goes on during the daytime, but I think I promised Nikki when I was going to talk about this I wasn't going to do much on tilt table testing. ECG, fantastic, yeah. So ECG at the moment shows she's in a sinus bradycardia. Do you want to do anything else with ECG? Echocardiogram? You might want to, but your cardiovascular examination doesn't really support that. Holter monitor, 24-hour ECG. I can recommend a very good paper written by somebody who's on the stage at the moment that says that if you look at 100 consecutive patients who have recurrent falls and look at their 24-hour ECG findings and compare those with normal, healthy elderly who haven't fallen, there's no difference in terms of the risk of the findings on Holter monitor. So Holter monitoring has its place in those in atrial fibrillation, where you may well predispose to a bradyarrhythmia as well as the tachyarrhythmia control that you get with AF, so the tachybrady component, who you might want to beta block, but they may need pacemaker. It's got its place in those who have an abnormal 12-lead ECG, so if you found a conduction abnormality on the 12-lead, you might want to demonstrate it over 24 hours, but arguably if you found it on the 12-lead ECG, you should act on it on the 12-lead ECG. But for looking for other bradyarrhythmic contributors, 24-hour ECG is probably worthless, and you need a longer period of monitoring. So a patient-activated device over several weeks might be the way forward there. But another 24-hour monitor.
I would want a sleep-deprived EEG.
Sleep-deprived EEG? You like spending money? Low blood pressure, yeah, so 24-hour ambulatory blood pressure. That's a very worthwhile thing doing. And I think it's something that is coming to the forefront, certainly with our primary care physicians. We're now getting the National Institute for Clinical Excellence in the UK is advocating that before starting antihypertensive therapy, patients, general practitioners should organise 24-hour ambulatory blood pressure. Now, some of that's a cost-saving measure. Why put all these people on drugs that they don't need? But we see, now perhaps less so, but a large number of patients in whom 24-hour ambulatory blood pressure identifies they don't need as much antihypertensive therapy. I work in the department of luxury, so we do continuous blood pressure monitoring when we perform an active stand test. So this is a trace from a continuous blood pressure monitor attached through finger cuff, so that we can see that you've got systolic, diastolic, and a very clear orthostatic drop. And in this individual with autonomic dysfunction, what you actually find is that that drop in blood pressure is both dramatic but sometimes short-lived. So by the time somebody in clinic would have taken a second clinic blood pressure reading using a sphygmomanometer, their blood pressure apparently hasn't dropped at all. So have that element of questioning still if the patient remains symptomatic with posture change and a straightforward 2 blood pressures hasn't shown it. It's not that dissimilar though to measuring the blood pressure every 30 seconds. So lie the patient supine, ensure they're supine for a good 5 to 10 minutes before you stand them up and measure the blood pressure accurately, and then every 30 seconds in the upright position for the first 3 minutes measure the blood pressure accurately and also measure the pulse. Because again, think about that subgroup, not usually elderly, but the younger patients who are lightheaded when they stand up, who have things like postural tachycardia syndrome, where the blood pressure is stable, but in fact they have a disproportionate tachycardic response. And here's a trace, again, 5 years old, but I see this on a regular basis. The patient with white coat hypertension who in clinic has the 158/70 BP. Send them away wearing a 24-hour monitor and you can see that their mean is floating along in the 100mm systolic. So it's little wonder they feel lightheaded all of the time. So in this individual, actually stopping the ACE inhibitor, reducing the atenolol, and then continuing their other secondary prevention therapies actually benefited the patient symptomatically. So it goes back again to Simon's talk on polypharmacy. It's about appropriate use of evidence-based drugs. And again, we start most of our patients on calcium and vitamin D3 and think about those patients who would need either a bone assessment, either in terms of a scoring system, which again we'll hear a bit more about, or whether you actually want to objectively measure using a DEXA. So again, going back to this issue of older people will often have more extrinsic things you can do something about, or there are medical issues that you can think about. Is the fall unexplained? Does the patient recall it? If they can't recall it, think about transient loss of consciousness. Are the injuries disproportionate? And I couldn't come out all the way from Newcastle upon Tyne, which is the centre for carotid sinus hypersensitivity, and not mention it. So carotid sinus hypersensitivity, an overreactive reflex in the carotid sinus, can contribute to cardio inhibition, which can be quite profound. So 3 seconds of or asystole or more, in those individuals they are at higher risk of unexplained falls, and certainly in single centre studies have shown that a dual chamber pacemaker can reduce both falls and future syncopal episodes. This was a patient from my earlier research with 8.5 seconds of asystole, which led to loss of consciousness when we performed carotid sinus massage. They had never blacked out, have a doctor. But they blacked out when I did CSM, and more to the point, after they had blacked out and come round again, they couldn't recall having blacked out, which goes back to the witness history incident. So if the patient falls suddenly to the ground, they have disproportionate injury, they won't recall that they blacked out because they weren't forming memory at the time they were hypoperfusing their brain. I've mentioned again lightheadedness. Think about that white coat hypertension. Think about culprit meds. Think about those patients who fall who have dizziness in particular circumstances, lying back in bed, those who are stooping forward for things. Think about BPPV. And again, Nikki I think is going to talk on this, but just to show the eye signs of somebody with BPPV as transient and torsional nystagmus that is elicited on a Dix-Hallpike manoeuvre. So that should start coming on any second now. There we go. And can you see there's that torsional component to the nystagmus there, which is characteristic and then subsides very quickly. So, evidence-based management in falls. There's lots of it about, and there are lots of meta-analyses about. And there are lots of meta-analyses that become confusing meta-analyses because they look at different trials, they include different trial criteria, and that's because fallers are not a homogeneous group of people. They're very heterogeneous. So you've got people who live a healthy life in the community, you've got people in residential care, you've got people in nursing institutional care, you've got people who are recurrent fallers as opposed to people who are single fallers. And that makes the literature confusing when you put all of these studies together in a meta-analysis. So I'll give you my simpleton's version because I'm a simpleton. This is a slide that John Campbell kindly gave me from New Zealand, and John's done a huge amount of work looking at exercise interventions. You'll all be aware of the Otago program of muscle strengthening exercise. And in that meta-analysis, he looked at single exercise interventions in terms of what is their effectiveness at reducing falls. And effectively, a pooled risk ratio of all of these small-scale exercise interventions showed effectively a 30% reduction in the relative risk of future falls with exercise programs. But you'll see, A, that the studies are quite small and the confidence intervals are quite wide. So a lot of these are small-scale studies which, when you put them all together, show that exercise works. Now, multidisciplinary studies are more expensive to run, so there are fewer of them. Even worse, there's no drugs involved, so there's no pharmaceutical companies sponsoring them. So we would like them to be bigger. But nonetheless, if you look, again, the seminal work would be Mary Tonetti back in '94. She looked at community fallers who may have fallen once, but most of them had never fallen, but had risk factors. If they've got targeted multidisciplinary intervention there, targeted at fall risk factors, then that showed not only a third reduction in the rate of falls, but you prevented people from converting to a non-faller to a faller. Blowing my own trumpet again, my study, we looked at people with an established fall history, and yet the reduction rates in falls are similar. But what we fail to do when you've got an established fall pattern is change somebody from being a faller to a non-faller. What you do is you just reduce the number of falls that they experience. But that has a knock-on impact in terms of, can you reduce fractures? And this is where the evidence base in falls is still struggling, is how do you demonstrate a reduction in fractures, because you need to examine thousands of patients in these studies for the study to be sufficiently powered to show that reduction in fractures. We've got nice guidance, and again, this is about asking people opportunistically if they've fallen, and looking, again, it's small print in terms of what you can see, but it's covering that multiplicity of things that you need to think about and assess for somebody who's fallen. Other things that we know work in single circumstances, in those who are vitamin D deficient, I think the evidence that making them replete in vitamin D is good. In those who are vitamin D replete, then it's up to these guys to be arguing about, well, what is insufficiency? And if you are insufficient, how much do you want to replace by? Home safety interventions, again, I mentioned environmental factors, but environmental factors work in those who have that as part of a multifactorial component and don't seem to work as a single intervention. Psychotropic medications, very difficult to withdraw, and John Campbell's work's about the only one that's looked at that. Expedited cataract surgery. Rowan Harwood in the UK, because of the waiting lists for cataracts in the UK at that time, was able to show a difference if you took the cataract out early, rather than they were sat for 18 months waiting for their cataract to be on a routine list. Now in the UK we've had the benefits that in fact we've now got very few patients who wait that length of time, so we're probably not seeing the differences that are occurring there. But other interventions for vision alone haven't really been as successful. And again, it's this multifactorial component of it. So if you look at modification of vision deficit alone, the studies say that even just changing spectacles, trying to correct amblyopia, doesn't on its own improve the outcome. And the successful vision intervention trials have also included exercise. So going back to these physios in there, put your hands up again. You see, you're not the majority, but you're plenty and full in numbers. It's the gait and balance work and the muscle strengthening that's probably the component there. There's something about podiatry as well. A footwear intervention was said to have shown benefit. That was work that came out from Stephen Lord in Sydney. But when you looked carefully, the group that got podiatry intervention also got ankle dorsiflexion muscle strengthening exercise, and it's probably the combination, not the single intervention of podiatry, that worked. In dementia, overall my colleague Fiona Shaw didn't show a reduction in the total number of falls in patients with an established dementia, and that may be adherence to an exercise program. But if you looked at her subgroups and looked at those where you could change medications, then there was some improvement, but it wasn't statistically significant because the group was too small. So what to do? We've mentioned a few investigations. I keep them simple. You want to be sure your patient's not anemic. You want to be sure they're not hyponatremic. Check their visual acuity and their contrast. A properly done active stand test. Check their ECG. If there's a suspicion of syncope, I perform carotid sinus massage. I perform Dix-Hallpike routinely on patients because it's an easy win. And there are very few things I do as a physician where I can find what the cause is, treat it, and have the patient go out thanking me in the same day. And then in terms of treatment, muscle strengthening exercise of a sufficient duration. So you need, the evidence base says they need to have prolonged intervention, muscle strengthening over 12 weeks or more. A couple of sessions isn't going to do the job. Balance exercise, certainly Tai Chi. I think there's now sufficient evidence compiled that suggests that Tai Chi is beneficial, but it comes down to expertise. How good is your Tai Chi expert, or do you have a different form of balance exercise which you're more comfortable and familiar with, and your patients are going to be familiar with, which is not going to be alien to their experience? If patients are going to benefit from exercise, you want to give them something they can continue to do. And there was a recent study in the BMJ that came out from Lindy Clemson, and again from Australia, and what they did there was they compared muscle strengthening exercise, which was part of everyday life, like making sure people were going up and down stairs regularly, rather than just doing muscle exercise from a static position. Thinking about bending and standing exercise, which was related to activities of daily living, and not only was the adherence to the protocol better, but in fact there were fewer falls in that group than in the group that were just given muscle strengthening exercise. So if you're going to give exercise, you want something that's not just for the benefit of you and that patient interaction on the day, when the patient's being on their best behaviour. You want them to carry on with that when they're not under your eyesight. Fall risk drugs we mentioned, so stop them. Don't stop them immediately unless they're performing, they are going to be an immediate threat to the patient. Reduce them gradually and have a program of reduction, looking at what was the indication for the drug in the first place, and then making sure that you're not doing harm by stopping the drug acutely. So to take home, as I said, a fall isn't a diagnosis, and because of that it's a very heterogeneous mix. So it's about keeping your mind open, it's about attention to detail, it's about asking those questions in all aspects. It's that comprehensive history which is critical. Think about targeting your interventions once you've found those reversible components. The only real single intervention that works is exercise, but I would say that works in people who aren't established in their fall history. So if you've got fall risk factors, target the exercise alone. If you've got an established fall pattern, then the medical assessment then becomes a crucial component of that as well. Think about syncope when the history is unclear, think about syncope when the patient's got disproportionate injury, and remember that bone health simultaneously, which should lead us on to Donald next. Thank you.
Thank you, John, for a very comprehensive and interactive presentation on prevention of falls. Open for discussion. Any queries, please? In the meantime, just a comment. A very important point in falls history is where do they have the fall? In research, there are some papers which say that 65% of falls happen in the home environment. about 30% happen in the community and 5% happen in the hospital itself.
So and I think again it relates to the accuracy of the fall data that we have. So I think there can be an underreporting of falls. There is an embarrassment factor with falling outside when you're in sight of other people. So there's an underreporting that potentially comes from that. Again, thinking of the seminal studies of intervention, Jackie Close in UCL in London, one of the things they had was a bi-disciplinary approach, which was an environmental assessment at home. They looked at changing potential fall risk factors in the home over which they had control. But in their follow-up period, 70% of the future falls that happened outside. Yet, despite the fact that the environmental hazards were external, the combination of a medical assessment and an occupational therapy assessment reduced fall rates.
I thought I would share some of my fall experiences with the audience here. First of all, Dr. John Tesan is from Newcastle. I was reminded of my own visit to Newcastle in July 1961 and had pleasant time with Dr. Scotthorne, who was the professor of anatomy there. I was a WHO fellow then. Then there are a number of calamities. Fall is a calamity. Calamities are three types. Natural disasters, which you can expect them. Natural disasters, you cannot expect them and it happens. And then man-made disorders like sabotage and all that. Here also, in the case of fall, I give my own experience. I learned scooter driving in my 57th year. One of my students taught me in St. John's Medical College. When I was doing it 100 kilometers or more per hour, I did not have any problem. But when I was doing hardly 25 kilometers, opposite Nimhans, Bangalore, a cyclist came across. In order to save him, I skidded a little, and I had a typical fall like this, classical fall with outstretched hands, the transmission of port, and then clavicular fracture. So, 58th year. Then everybody said, at this age, why do you want a two-wheeler? I said, okay, I'll put on a sidecar. 23 years I rode a scooter with a sidecar. And then there was no chance for an accident. I call this the rule STD, stop, think and do, which I didn't do. Opposite a gate, I wanted to park my vehicle on the left side, but something told me I should park on the right side. And without seeing a two-wheeler coming very fast, I went across. The two-wheeler hit me. Nothing happened to my scooter, but I broke my neck of the femur, right side, which has been replaced. That is the 2004. I call it STD because many of these things are avoidable, provided one thinks beforehand. The other thing I wanted to mention is, many of these falls are in bathrooms. With the tiles, where it's very slippery. I don't know, they still do that. The larger the bathroom, the worse. And these days, even in the hotels, we talk of elder care. They don't provide for elders. So I'm 88 plus now, in my 89th year, having had my replacement about 8 years ago. Even when I go to the hotels, I see that it's a risk going there. So they don't provide side handles for, so if it is a little narrow, it's all right, you can take help of the walls and support yourself. So that's the problem with the modern advance. Most of them are with tiles, of course they're changing now. They are slip-proof tiles they are having these days. So I wanted to share these experiences with you, and but for this I would still be walking without any problem. But now I have a walking stick and there's a little wobbling a little, can't help.
Thank you very much for your anecdotes. Sir, do you have any question for which will help you not to
I
break
would
the other
like
hip?
to add to your list that many of these accidents are preventable. I hope you agree with me.
I agree, and I think
Provided
you've also
with
highlighted.
people think rash driving, for example, on the road, it's easily avoidable. Especially I see two-wheelers going like a snake, like this. So, I have no problems at my 18
Thank you, sir.
no,
Thank you
no
for your-
other problem, except for the fact that I'm a little unsteady in my walk, and I'm not using any, even for my arthritis of both the knees, I'm not using any allopathic drug. I'm using only Ayurvedic oils and regular quadriceps exercises wherever it is possible. Sitting on a chair, just stretch the legs, imagine you're lifting the table and all that. That gives enough of exercise for the quadriceps. Everybody thinks you must go to a gymnasium for exercise, not necessary. Wherever
Thanks
you
for your
are, you can
message,
do
sir. Thanks for your
that.
message.
So I hope,
The next question, please.
you agree with me?
Oh yeah, and I think you've highlighted what often happens with exercise, with accidents, is that many people afterwards go, why did I do that? I could see that coming. And it's back to this issue of people actively thinking. And again, patients with orthostatic hypotension, the hardest thing for those individuals is to change, because they, in all circumstances, will go back to their normal habits, which is to stand quickly. And many of them in clinic, I'll see them, I'll explain what they need to do, I'll explain about isokinetic muscle exercise before they stand up, and they'll say, thank you very much, doctor, and they'll stand straight up and they'll walk out the room and then go like that. So it's trying to get people to change the way they think at times is helpful. Okay.
Why was, sir, this is a question. Why was this 87-year-old lady put on zolpidem 7.5 milligrams?
I have no idea why that lady was put on the sedative.
We
of that
hardly,
strength.
non-benzodiazepine hypnotics are to be used with a great deal of caution
Absolutely.
in people above 70 years of age.
Yeah.
A better drug would have been, if I assume that zolpidem would have been started for sleep problems,
Yeah.
melatonin, Melocet 3 milligrams a day given at 7 p.m. would have been a better choice.
Thank you.
Yeah.
Good. Anybody here? Any further questions?
Regarding patient falls in the hospital, what is your thing about restraints, bed rails and things like that?
Okay, I didn't really touch on inpatient falls, partly because I think it's not entirely a controversial area, but I think the evidence base is less strong. So the meta-analysis that was done by David Oliver about 2 years ago looked at a combination of what interventions can help reduce falls. And the overall outcome with that is that a combination of having appropriate devices for patients, so appropriately placed walking aids within the hospital and an early evaluation of that, managing delirium, providing patient information, ensuring your nursing staff are trained to observe patients and assist them appropriately, regular toileting for patients so they're not trying to get up, ensuring that you have got a situation where in fact you're looking at things like low-rise beds rather than restraints or bed rails, that overall can reduce falls by about 18%. Now, within the UK, the Royal College of Physicians has just published the Fall Safe project, and that's looking at implementation in UK hospitals, looking at those specific range of measures, and a nurse who's trained to be able to provide appropriate aids to very quickly after patients are admitted to hospital, and incorporating those, and that's now starting to show some reductions in inpatient falls. But it's again, it comes back to numbers. If you've got a large number of events, organisations like hospitals struggle to understand that the investment to reduce those numbers, even if you're not abolishing the inpatient falls, is worthwhile doing.
So we'll give you a chance next time because it's about osteoporosis.
Yeah. If I can just ask John, most of my old patients have got cervical spondylosis.
Yeah.
They have partially blocked carotids.
Yeah.
And they have this complaint of lightheadedness and a tendency to fall.
Yeah.
Objectively, what's the contribution of these other comorbid conditions to the falling? apart from the autonomic
The evidence
dysfunction that we
base isn't
perceive?
very strong, because if you look at that age group and look at those who have got restriction of flow within their carotids and who have cervical spondylosis, there's no difference in the proportion of those patients who are fallers versus non-fallers. And similarly with some of those subjective feelings of dizziness and lightheadedness, there doesn't seem to be a clear enough correlation because the symptoms are so common and because cervical spondylosis is so common. I think there is a component that if you have a painful neck, then you restrict your head movement to help compensate with your balance. So that if it hurts to go like that, and you start falling that way, and your component to help maintain your equilibrium is to tilt your head, because that brings you back into line and it's painful to do, you're going to get additional sway, and that additional sway is going to put you at risk. So things like mobility, exercise within the neck, within the constraints of their physical limitations and pain, is probably beneficial as part of the overall package. But it's the lower limb strengthening exercises that have come out strongest in terms of those that have had a full reduction effect.
Thank you for a nice lecture. In my limited experience, I have found one of the important causes of falls is a dorsiflexor weakness, be that due to any cause, either peripheral neuropathy or even lumbar spondylosis. When there is a weakness of the dorsiflexors, you tend to trip and fall. Is this a fact or a fiction?
No, it's very true. An ankle dorsiflexion strength is an independent risk factor for falls. And again, going back to the study that came out in Australia that was looking at podiatry intervention, I think Spinks was the first name author, but again, it was Stephen Lord's group. It was ankle dorsiflexion exercises which were the particular component of exercise intervention there. I didn't do one of the other things I sometimes get people to do, which is to stand up and then curl your toes up and go up onto your heels and see how well you can balance in those circumstances, unless everybody wants to do that again before the next talk.
If an elderly person comes to the clinic for some other reason, let's say some other problem, but in the course of history, does give history of falls, the concerned physician does not take adequate measures for that, he goes back home and falls a week later and sustains a fatal injury. What are the consequences?
The consequences to the patient are fatal.
Doctor, patient's consequences are already settled.
I think it's all about, there are certain questions as physicians you don't always want to ask because you know you're going to put yourself into a long answer. And one of those is, how are you? One of those is, are you feeling dizzy? And one of the others is, have you had a fall recently? But in fact, again, the recommendations within the UK framework are that our general practitioner colleagues and us as physicians should proactively ask that question to people over the age of 70, if only to start that first bit of doing a very simple gait assessment and asking about, you can ask the question about their walking, their gait and their balance and ask if they've got any unsteadiness, or you can get them to go and do a timed up and go, which is very simple, and that would direct you into taking interest in.
Falls is a major problem. It is contributing to health economics in geriatric care. Unless there's some sort of friction, then you go on. I'm sure in our practice we don't ask that question. When the person comes, it used to happen that he goes back and falls and sustains the injury. It's a recurring cost for the family. For the
Absolutely. So I hope the message that comes from that is you're going to ask that question and act on it in future.
Okay.
There's only one line question which I wanted to ask. There's a loss of confidence in the much advertised calcium tablets these days. So I don't know what calcium would you recommend in case of osteoporosis and all that?
Sir, I would request Dr. John not to answer this question because
I'll ask Donald to
it's the subject of the next talk.
Yeah.
It's the subject of the next talk. So please, that's why I requested you not to ask this question now. It would be unfair to the next speaker. Thank you very much, Dr. John, and particularly for the fact that you have steadily stood there with no sign of imbalance for a very long time and given us this meticulous lecture which showed us how complicated this topic is and how much of care one should take in evaluating the fall and ensuring that therefore we get a proper diagnosis and proper treatment. Thank you very, very much. It was an educative experience. Thank you.
The consultant general physician with interest in geriatric medicine. He works at St. John's Hospital, Livingston, near Edinburgh. He is chair of the Medical Specialties Training Board for Scotland. He is Assistant Dean International, the Royal College of Physicians, Edinburgh. Dr. Fakir, please. He will be speaking upon osteoporosis, evidence-based interventions for thin bones and fractures.
Okay. First of all, obviously, I'd like to thank everyone for the invitation, particularly the learned bodies over my left-hand side. I've found the talks this morning and the entertainment we had yesterday a very enjoyable experience and an educational experience. And what I'm trying to do now is to really look at the other side of the equation, which has been raised so expertly by John at the start. Clearly, people who fall over are at risk of fracturing. And what we have here is pictures of bones, and I'm sure all of you in the audience can recognize the bone on the left, on the right, sorry, as you're looking at it, is osteoporotic. And I want you to look specifically at what makes it osteoporotic, just visually. And first is that you have a significant loss of bone mass. So the total bone mass, if you look at the thickness of the bone, the thickness of the linkages between the bones, so that you have a general loss of bone mass. And you also have a loss of bone quality. You can see that the bridges are broken, the little yellow arrows are directing a place where the trabecula have broken because they've become so narrow. So that osteoporosis is a condition really of reduced bone strength brought about by a combination of the loss of bone mass and of bone quality. In measurements, when we're actually studying bones, we tend to concentrate on the bone mass because it's easier to measure, but bone quality is also important. These are the classic osteoporotic fractures that we always think about, but surgical neck of humerus, fingers, toes, they are all osteoporotic fractures. And when we tend to think of osteoporotic fractures, they're often called low trauma fractures, and that's really fractures which occur from a standing height, from a stationary position, are the fractures that place you at risk of osteoporosis. And if we look, the fractures really start to occur in your 40s, Colles fractures or a wrist fracture being the one that often starts to appear first. But you'll see from the line on the Colles fracture that in fact the incidence never really increases dramatically. Vertebral fractures then take over, really huge increase, a linear increase in the risk as you age, and this is going on through your 50s and 60s, and certainly I see many people with multiple vertebral fractures who are in their 50s and 60s and suffering a great deal of pain. And then we get to the big disaster fracture, which is the neck of femur, a fractured neck of femur. Certainly in the UK and the US, it accounts for 85% of the cost of dealing with osteoporosis, because they need to be hospitalized, they need a great deal of care, they may need family care, they may need nursing care, and certainly in many countries they all need operative care, which costs money. So hip fracture is the driver for the costs in osteoporosis, and there are a variety of reasons for that. This is a slide really just to try and link together the last talk and my talk. And I think I've got a laser here. I have. So this is a major study of osteoporotic fractures from North America. And on this axis down here, we have bone density. And what you have here is just in thirds, top bone density, bottom bone density. And in the other axis, we actually have a basket of risk factors. And these were risk factors for fracture, which tend to be a mixture of things that weaken bones, like a previous fracture or a maternal hip fracture, and things that are associated with falls, like being on your feet less than 4 hours, being unable to get out of a seat unaided. So a basket of risk factors. Now, if you've got no risk factors, if you have very few risk factors, you'll see that your bone density isn't particularly relevant. Even with the lowest third, your risk of fracturing doubles, but the absolute risk remains very low. Whereas, no matter how good your bones are, you've got the highest third, so your bones are in the top third for your population, but you have lots of risk factors. I think this just demonstrates that if you fall often enough, as John was saying, sooner or later you'll sustain a fracture. And then if you combine lots of risk factors and bad bones, you end up with a very, very high risk. And this really just demonstrates the synergism that we have between falls and fractures. This is just a quick slide to tell you what is happening to your skeleton through your life cycle and the differences between men and women. So in the first 25 to 30 years, you are all reaching your peak bone mass. So you reach your peak bone mass by 25 to 30. And men are bigger and have thicker bones, well, bigger bones, therefore they always will have a peak bone mass that's higher. Anything that affects your peak bone mass and your attainment of peak bone mass will mean that you start off, you reach a lower peak bone mass, and that will result in higher risk to you in the future. So your nutrition during your adolescent years, any illnesses that occur during your childhood years will give you potentially a lower peak bone mass, and you are already programmed to run into difficulties 30 or 40 years later. We then have a position where in general for the next middle years we're relatively okay, but then women at the time of the menopause have accelerated bone loss where you're losing anything between 10 and 20% of your bone mass over 10 years at the time of the menopause. So really a dramatic change, and that means that just after the menopause is the time when the difference in peak bone or bone mass between women and men is the greatest. Everyone is losing bone as they age, but you can see here that women enter a sort of the risk zone for fractures at a much earlier stage than men, so that we tend to see many osteoporotic fractures in women in their 50s, 60s and onwards, whereas male osteoporotic fractures tending to pick up perhaps in the 70s, early 80s. So there's a difference in age, and that really says why 1 in 3 women will sustain an osteoporotic fracture, but only 1 in 10 men. Men get osteoporosis, but they get it later. And this is a slide just to demonstrate this in a different way. There's a famous epidemiological study of osteoporosis in New South Wales, and this is actually the study, similar to Framingham for cardiovascular. And I'd want you just to look first of all at people in their 60 to 69, which as a geriatrician in the UK is still young. So the idea of 65-year-olds being young, as that time approaches for me, I see that as relative youth now. And you'll see that here, first of all, the fracture risk is not dramatic. Women are roughly twice as likely as men to fracture at that age. And the bad fractures, vertebral fractures and hip fractures, are very uncommon in both groups. You look as an alternate to the over 80s, and you get the huge difference in fracture rate, in the numbers of people who fractured between people in their 60s and their 80s. Men have caught up. Men are now fracturing, and the difference between men and women seen here has gone, and crucially, the bad fractures now predominate. So proximal hip fractures and vertebral fractures now comprise the big groups. Obviously, we've all been trying to find out a little bit about our areas of interest in India prior to this visit. And it's clear that India is increasingly recognizing osteoporosis as a health concern. The document on the left suggests that on a very conservative estimate you have 36 million people currently with osteoporosis in the country, and that is only going to explode in the next few years. And clearly there are patient and consumer papers such as the one on the right which talks about how people as individuals can try and avoid osteoporosis. This really just details what might be expected. We've already heard this morning on multiple occasions about your aging population, and this really just demonstrates the aging population increasing all the time. And this is the estimated number of hip fractures. So that my learned chairman over there are looking at a situation of perhaps somewhere about 500,000 hip fractures to deal with, and in 30 years' time, that could be 1.5 million fractures. You are facing a massive explosion unless we can design strategies, or you can design strategies to try and minimize this increase, which is bound to occur as your population ages. The consequences for hip fracture are major for the country because they often have health costs, but they're also extremely important for the individual. This is a study, it's now 20 years old, but it hasn't changed much. It is based on UK practice, and I suspect would be rather different in India. But this looks at people before their fractured hip, the majority at home, but a significant proportion of people falling in either care homes, meaning nursing homes, or in hospital. After a year, 40% of those people were dead. Now, the mortality in the first few weeks after hip fracture in hospital runs at about 15%, but there's a very substantial mortality in the remainder of that first year. And those people who do get home are only half of the people who came from home. So you fracture your hip, very substantial risk of dying of the experience, and a very substantial risk that you will not return home in the UK. Or in India, I suspect the family would need to take on the care, and that would have a big impact on how you would be able, on the way you would need to manage the situation, and on the quality of life of that individual. So what are the potential strategies? And there are a number of strategies which can be used. First is public health. Now, if you can make changes in your own public health measures in India, you could have a dramatic effect on the actual prevalence of thin bones and by definition reduce fractures at that point. So thinking about diet, increasing exercise, reducing smoking, reducing alcohol consumption. So these are things to think about. General big measures, but small changes that happen throughout the population would have very big effects on numbers. Then what's the evidence base means, the best way of actually identifying those people at risk of osteoporosis and confirming the diagnosis. And you then need an effective intervention which you know will reduce the risk of fracture. I'm going to try and dwell briefly on these three areas. So this is the data I could find about diet, and the two big building bricks for bones are clearly calcium and vitamin D. So the graph on the left talks about average dietary calcium intake per country, and this is a basket of Asian countries. And you can see India here comes out at about 350 milligrams calcium per day. Now, the International Osteoporosis Foundation recommends that for all adolescent girls and for all postmenopausal women should be taking a minimum of 1,000 milligrams of calcium daily. So the daily calcium intake in India is 1/3 of what's required for that population. So changes in calcium intake could potentially have a very major impact. Vitamin D is also important. As we've heard, we're not absolutely sure if it's important in improving quality of bone or perhaps stopping you falling over, but it is important in fracture reduction. And vitamin D insufficiency is labelled as less than 50 nanomoles per litre. Vitamin D deficiency, less than 25. And this is insufficiency figures from a study in North India, and I think these are pretty scary figures. I think naively people in the UK see your wonderful sunshine and think, well, very sunny country, you won't have a problem. I'm afraid it seems like you do. I suppose many people cover up quite well, that you also, your diet, you're needing to look for things, oily fish, other things like that, and other agents to get you your vitamin D. The sun helps, but you also need some substrate to work with. So I think there is work in public health that India could be doing, and frankly so could the UK, because we have similar problems, but our calcium intake, for example, average calcium intake is about 700 to your 350. The next is, how are we going to identify people who are at fracture risk? And there are a number of risk scores. The two biggest being FRAX, which I'm told is about to produce a FRAX calculator for India, but it's not there yet. Another one called Q-fracture. Now these are ways to try, or you can put a patient through a scoring system and you can give them their fracture risk. And the Q fracture doesn't need a bone mineral density, nor does the FRAX. These can be done without access to scanning. The real problem in elderly people is that age is the main driver for risk in fracture, and if you're old, all your old patients will actually have a high score. And I tend to find that in over 70s everyone has a high score, and I don't find these particularly useful. I think they're very useful in perimenopausal women who are worried about osteoporosis because they're 45 or 50. You can put them through this and say, your risk of fracture in the next 10 years is negligible. We don't need to take this further. But for an elderly population, I don't think this is the answer. And this is the answer, evidence-based wide, but creates another problem from what I can see in India. DEXA scanning is dual energy X-ray absorptiometry, and this is the machine that you can see here. It's low energy ionizing radiation, so you don't need lead-filled rooms or anything like that. You can have a technician just sitting next to it. It can sit in a normal office. WHO have defined osteoporosis by the use of this machine. So all of the drugs that we have been proven to work in osteoporosis have been proven to work on people who were proven to have osteoporosis by a DEXA scan. There is no evidence that identifying a group of people with risk scores and treating them will necessarily have the same effect. And the International Osteoporosis Foundation suggested that India has a very low availability in DEXA scanning, with perhaps 250 machines in the whole country. And we have about 250 machines in the UK for obviously a minute fraction of your population. So I suppose if there's any entrepreneurs in the room, a DEXA scanner might be something to think about if you're wanting to develop an osteoporosis service. It is the way of actually being able to come to a firm diagnosis. Then it's how do we actually spot the people with osteoporosis who we can be dealing with? Because I've said there's 36 million people out there in India. How on earth do you spot people with that condition? And osteoporosis is often thought of as an iceberg. At the bottom we have a huge number, all the postmenopausal women. Then postmenopausal women who at some point have become osteoporotic, but they may not have had a fracture yet. Then a group who've actually fractured, but it might have been 5 years ago, and how are you going to identify that person? Only if they happen to come in and you see them and find out that they've got that fracture. But the group that you can actually clock and spot easily are the ones who've just fractured. So osteoporotic fractures new this year. And in many countries now, we have a fracture intervention service where you actually actively search out all the people who are presenting with low trauma fractures over the age of 50 and try and identify if those individuals have osteoporosis. We have no qualms about somebody who's just had a heart attack or a stroke in treating them with aspirin, treating them with clopidogrel, starting them with a statin. But we seem to be loath when you've had your first fracture to think about doing something to stop them having their second fracture. And this is the title for the World Osteoporosis Day this year. Stop at one, make your first break your last. So when you identify, when somebody turns up in the emergency room with their fractured hip, with their fractured cervical neck humerus, with their fractured colles from a low trauma event, think about what you can do to prevent further fractures. So the things you can do, first of all, you can think about case finding. If you spot people because they're coming in for something else, or if you have a primary care organisation, they may be able to spot people who have an early menopause, who are on steroids, who perhaps have rheumatoid arthritis or other conditions associated with osteoporosis. The big group here, secondary prevention after your fracture. And 1 or 2 countries are actually embarking on population screening. A few HMOs in America and Germany are suggesting we will scan everyone over at the age of 65 and identify an at-risk population. No one else thinks that's cost effective, but that's currently the way 1 or 2 countries are going. So this talk was very much about evidence-based, and we've seen the evidence-based plots that John's already shown you for some of the falls interventions. What we want for any drug that we're going to use in osteoporosis is that it has grade A evidence, which is the top class evidence, big randomized controlled trials, and it has evidence that it'll work on all fractures. There are a few agents which seem to affect vertebral fractures, which are the easiest to prevent, but have no impact on hip fractures and non-vertebral fractures. So we really want to be using agents which will reduce hip fractures as well as vertebral fractures. And the 2 agents that tend to be used very extensively worldwide are the calcium and vitamin D. Now that's 1,000 milligrams of calcium and 800 international units of vitamin D. That's the minimum concentration. Trials that have looked at lower concentrations of vitamin D, for example, have shown no benefit. And the oral bisphosphonates, once a week oral bisphosphonate, and the biggest one is alendronic acid, also known as alendronate, also called Fosamax. And these 2 agents are cheap. They are cheap as chips, as we say in the UK. So they are cheap to actually provide, but they are effective. And then we have some more expensive second-line therapies. I'm just going to quickly run through these agents. So this was the first study showing real efficacy in a randomized controlled trial to reduce non-vertebral fractures. It was basically in France, and it was giving calcium and vitamin D in the concentrations I've just described to frail elderly people. And those were staying in nursing homes or retirement homes in France. And giving just calcium and vitamin D could reduce the odds ratio by 30%, so a 30% risk reduction in fractures from giving calcium and vitamin D. And this was a very elderly population. The oldest person randomized into this study was 101. So, good evidence base in elderly people. However, there's been a lot of studies since looking at calcium and vitamin D, and I'd have to say with contradictory results, some positives, some negatives. So again, we tend to look at meta-analyses where we try and take in all the big studies and tie them together. And using probably the biggest and best known meta-analysis from Belgium, that suggests again that vitamin D by itself doesn't seem to do the job. Not as far as reducing hip fractures. But as far as calcium and vitamin D is concerned, perhaps an 18 to 20% benefit. So calcium and vitamin D is effective in a particularly frail elderly, the over 75s, people who don't see the sun very much, and in the UK many of our elderly live alone, don't get out the house and never see the sun. We then come to the once-a-week bisphosphonates. Alendronic acid, residronate is the other main one. And this is just a basket of studies to just demonstrate the relative risk reduction at multiple fracture sites. So a once-a-week tablet that you take with calcium and vitamin D. So it's calcium and vitamin D and alendronic acid will result in these sorts of reductions. And effectively it's about a 70% reduction in vertebral fractures, which are the easiest to impact on, 50% reduction at hip, and about 20 to 30% reduction in a basket of the other non-vertebral fractures. So this agent works. And it's good, and it's by far the most commonest, this is by far the most commonest use of drug use in the world in osteoporosis. However, we have concerns about these drugs. We still don't know whether you can give the drugs ever. If you're